Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 429 of our pharmacotherapy series, which majors in adverse effects of chemotherapy and targeted agents. The next case reads, WJR, a 15-year-old boy with osteogenic sarcoma of the right knee, is to be treated with chemotherapy consisting of high-dose methotrexate with leucovorin rescue, doxorubicin, and cisplatin. The dose of methotrexate is 12 grams per meter squared IV administered over 4 hours. So my question to you is, what precautions are necessary to prevent the renal and other toxicities associated with high-dose methotrexate therapy in WJR? Methotrexate normally is not nephrotoxic, although 90% of the agent is excreted unchanged in the urine. However, acute tubular obstruction can occur with high-dose methotrexate if appropriate precautions are not taken. Acute tubular obstruction is caused by tubular precipitation of methotrexate, which is poorly soluble at a pH less than 7. To prevent this, WJR should receive hydration and brisk diuresis to produce urine output of 100 to 200 ml per hour for at least 24 hours after administration. A urine pH greater than 7 usually can be ensured by administration of 25 to 150 milliequivalents per liter sodium bicarbonate within the hydration fluid. WJR's urine output and pH must be monitored closely to prevent acute tubular obstruction during this period. In addition, intrapatient and interpatient variability in methotrexate clearance is considerable, particularly with high doses of methotrexate therapy. Renal excretion of methotrexate is a complex process involving glomerular filtration, tubular reabsorption, and secretion. Acute tubular obstruction associated with high-dose methotrexate therapy can be prevented only by appropriate attention to optimal urinary output before, and for at least 24 hours after, high-dose methotrexate administration and urinary alkalization. If WJR has existing renal insufficiency, methotrexate excretion will be decreased, leading to higher systemic exposure. As a result, myelosuppression and mucositis can become more problematic. Leucovorin, folinic acid, is a reduced form of folic acid given after methotrexate administration to selectively rescue normal cells from adverse effects such as myelosuppression and mucositis. Because leucovorin is already in reduced form, it can bypass the action of dihydrofolate reductase and not interfere with methotrexate's inhibition of this enzyme. Therefore, It is important that leucovorin rescue is initiated 24 hours after the high-dose methotrexate infusion. Blood concentrations of methotrexate obtained within 24 hours after the infusion often are not predictive of concentrations at 48 hours. Therefore, methotrexate concentrations between 24 and 48 hours after infusion must be monitored in WJR and in all patients receiving high-dose therapy. Methotrexate levels are necessary to guide leucovorin dosing. Leucovorin rescue does not affect the renal clearance of methotrexate. A rescue agent, glucarpidase, is indicated for the treatment of toxic methotrexate concentrations in patients with delayed methotrexate clearance due to impaired renal function. Glucarpidase is a recombinant bacterial carboxypeptidase enzyme that converts methotrexate to its inactive metabolites, and provides an alternative route for methotrexate elimination in patients with renal dysfunction and signs or symptoms of methotrexate toxicity. After WJR's surgery, it is decided to add ifosfamide to his treatment. So my question to you is, what bladder toxicity occurs with ifosfamide that requires attention before its administration? Regarding the pathogenesis, ifosfamide is a structural analog of cyclophosphamide belonging to the oxazophosphorine class of anti-tumor alkylating agents, which must be hydroxylated and activated by the cytochrome P453A 4/3 A5 and 2B6 enzymes in the liver. The 4-hydroxy metabolite spontaneously liberates acrolane, which is excreted in high concentrations in the urine. Acrolane is responsible for urotoxicity, causing a direct irritation of the bladder mucosa. Both ifosfamide and cyclophosphamide can produce cystitis, which ranges from mild to severe bladder damage and hemorrhage. Cystitis is characterized by tissue edema and ulceration, followed by sloughing of mucosal epithelial cells, necrosis of smooth muscle fibers and arteries, and culminating in focal hemorrhage. We will now look at the clinical presentation. Patients with acrolane-induced hemorrhagic cystitis initially go through an asymptomatic stage characterized by complaints of brief episodes of painful urination, frequency, and hematuria. The symptoms may subside over a period of several days or weeks after discontinuing the agent. The course of acrolane-induced hemorrhagic cystitis usually is relatively benign, although death from massive refractory hemorrhage has occurred. The primary factors that may predispose WJR to hemorrhagic cystitis include the dose of ifosfamide he is receiving. Let's briefly discuss prevention. Historically, forced hydration was the primary method used to prevent hemorrhagic cystitis in patients treated with cyclophosphamide therapy. Theoretically, hydration flushes the toxic acrolane metabolite out of the bladder so that insufficient contact time is available to set up the tissue reaction. The more urotoxic agent, ifosfamide, was introduced to the market with a uroprotective agent, Mesna. This agent contains a free thiol group, which can neutralize acrolane in the bladder. When administered in an appropriate dosing schedule, Mesna can prevent the bladder toxicity completely, and thus use of Mesna is the current standard of care. The ASCO guidelines recommend a parenteral Mesna dose of 20% of the ifosfamide dose given at 0, 4, and 8 hours after ifosfamide, for a total Mesna dose of 60% of the ifosfamide dose. The goal is to maintain prolonged mesna concentrations within the urinary tract that are uroprotective. Repeated administration is required because mesna has a much shorter elimination half-life, that is less than 1 hour, than ifosfamide. If patients receive a continuous infusion of ifosfamide, a different dosing strategy for mesna is required. To prolong mesna's protective effects, ASCO guidelines recommend an IV bolus mesna dose that is 20% of the ifosfamide dose, followed by a mesna continuous infusion that is an additional equivalent of 40% given during and for 12 to 24 hours after the end of the ifosfamide infusion. This regimen ensures that mesna remains in the bladder for an extended amount of time after the end of the ifosfamide infusion. Various other mesna dosing schedules are clinically used, but no trials have compared the different regimens. Many clinicians use a 1 to 1 mg dose of mesna to ifosfamide when administered by continuous infusion. The dosing guidelines become less well defined. However, when patients receive higher dosages of ifosfamide, that is greater than 2.5 grams per meter squared. The lack of data and the unique pharmacokinetic properties of ifosfamide have caused some concerns about the current dosing guidelines. The pharmacokinetics of ifosfamide are nonlinear. For example, the elimination half-life associated with doses of 2.5 grams per meter squared is 6 to 8 hours, whereas with doses of 3.5 to 5 grams per meter squared, it is 14 to 16 hours. The current recommendations for mesna administration enable protection for approximately 12 hours after an IV bolus. Thus, with higher dosages of ifosfamide, mesna should be infused beyond the recommended 8 hours after ifosfamide to maintain bladder protection. Also, concern exists that the 4-hour dosing interval used with lower doses may be inadequate to maintain sufficient mesna concentrations within the bladder. To ensure maximal protection against urotoxicity, ASCO currently recommends more frequent or prolonged mesna dosage regimens to account for its short half-life. Ifosfamide and mesna are compatible in solution. Therefore, they can be infused together, offering greater patient convenience. Because mesna works in the bladder, frequent urination may diminish its efficacy. Patients may be reminded to try to empty their bladder every few hours. Although forced hydration has been the mainstay for prevention of cyclophosphamide-induced hemorrhagic cystitis, it is unnecessary and potentially disadvantageous when mesna is used. This is because forced hydration can increase urination and thus the evacuation of mesna from the bladder. Mesna is usually given IV, but an oral formulation is available. The oral bioavailability of mesna is approximately 50%. Therefore, patients should receive twice the standard IV dose, e.g., oral mesna 40% of the IV ifosfamide dose, 2 hours before and 4 and 8 hours after ifosfamide. Others have recommended that an oral dose also be given with the ifosfamide dose. Many centers administer the first dose of mesna IV followed by oral doses at 4 and 8 hours, particularly in the outpatient clinic setting. All patients receiving cyclophosphamide should receive saline diuresis or forced saline diuresis to protect urothelial tissue. When patients receive cyclophosphamide for an HCT, it is at high dose. Therefore, they receive mesna and hydration. Other practices to prevent this complication include hyperhydration and the use of continuous bladder irrigation. Data comparing these methods are controversial and report varying rates of hematuria and severe hemorrhagic cystitis. These recommendations are currently supported by the ASCO consensus guideline. WJR will receive Mesna at a dose of 20% of the ifosfamide dose given immediately before ifosfamide, and at 4 and 8 hours after ifosfamide, for a total Mesna dose of 60% of the ifosfamide dose. My next question to you reads: if WJR exhibits hemorrhagic cystitis, how should it be treated? Once hemorrhagic cystitis develops, the agent causing the disorder must be discontinued and vigorous hydration started. If gross hematuria occurs, a large-bore urinary catheter should be inserted to avoid obstruction of the urethra by clots. Some clinicians also use continuous silver nitrate irrigation, local installation of formalin or alum, or electrocauterization of bladder blood vessels to control bleeding. There is no consensus as to which of these methods is superior. If these measures fail, surgical intervention may be necessary to divert urine flow away from the bladder. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 430.